into. It feels like a pretty high bar there. We'll see what we can do. First of all, I want to thank all of you for being here, and I want to thank the participants and the organizers for putting this conference together. I'm a healthcare guy. I ran Harvard Vanguard Medical. I was the Secretary of Health and Human Services back in the 90s, and as Paul mentioned, I was the CEO at Harvard Pilgrim for 10 years, and I spent the last few years before I ran for governor in 2014 as an investor working for General Catalyst, which is a local venture capital and growth equity investor in the healthcare space. So I consider myself to be a healthcare person per se. And as I campaigned this, I did not get into the race for governor specifically to deal with this issue. I certainly knew that as a healthcare person, I was going to bring a different set of perspectives to those issues than maybe some others as a practitioner. But I ran mostly to talk about jobs and schools and building strong communities and trying to expand and improve on our economy in the parts of Massachusetts that really haven't benefited from a lot of what we've seen as the big bang recovery here over the course of the past 5 or 6 years. But as I campaigned around the Commonwealth, I was astonished by how many times I would be in somebody's living room or in a diner or in somebody's conference room or somebody's backyard, and somebody in the group would come up and start talking to me about addiction, and especially and specifically about opioids and heroin. And it didn't matter where I was. It didn't matter what part of the Commonwealth I was in. It didn't matter what kind of neighborhood I was in. It didn't matter what the socioeconomic demographic makeup of the group I was talking to was. It was literally everywhere. And so I started to talk a little bit more about it toward the end of the race, but it really wasn't kind of a fundamental, I think, that people took into the voting booth when they voted on election day, but it was certainly something that I had been surprised by the response to as I'd campaigned around the Commonwealth. And then between the election and the inauguration, the election was November 4th, the inauguration was January 8th, and most of this is for the people who aren't from Massachusetts. It's probably more background than the people from Massachusetts care for. Apology. Some reporters from the Globe came to my house to do an interview with me about what I might want to concentrate on early on in our administration. And I told them a story about my son, AJ, who broke his arm in a football game. He plays football for Union, and they were playing Hobart literally the weekend before the election in a typhoon in upstate New York. And we were barnstorming around the state, my wife and I, and we got a phone call from him. He was in an ambulance on his way to the hospital in Geneva, New York, because he'd broken his arm in 2 places. And my wife and I then had a big debate about whether we should just blow off the rest of the day and go see our son. And he basically said, you can come here if you want, but you're not going to be worth, or you can't do anything for me. So, you know, you got to love kids. So we basically continued to campaign and all the rest, but we had a very heart-to-heart conversation with him a couple days later in which I said, look, I am sure, and by the way, he didn't need surgery and he's better and all the rest. Happy ending, okay? But we had this conversation with him about pain medication, and because of the avalanche of stories that I had heard over the course of the campaign, I said, look, you know, if you want to take a few of those, okay, but please take a few of them and then stop, and we'll come up with, we're happy to talk, we'll come see you, we'll do whatever we can, but you really ought not to spend a heck of a lot of time with these things because, frankly, they're dangerous. They're effective, but they're dangerous, and you need to understand that. And I told this story to the reporters and said, I really want to make this an issue that we spend a bunch of time on early on in our administration. So the Globe wrote the story, and they said that. And then the avalanche coming from the public came again, because I had told what I thought was one of many stories that I told that showed up in this story about priorities and things we cared about. But this one strikes a nerve in a way that, frankly, I've seen very few issues in healthcare strike a nerve. It's a big, complicated space, It's administratively complicated. It's clinically complicated. It's complicated in every way, shape, or form you can think of. But to a lot of people across many communities, not just here in Massachusetts, but elsewhere around the country and probably around the globe, this isn't that complicated because it's about somebody in their family. And addiction, as all of you know, while it may be metabolically complicated, it is incredibly complicated for the families that have to struggle and the individuals who have to struggle their way through it. So we took office, and I talked about this specifically in my inaugural address and said that this was something I wanted to put together a working group on. Health and Human Services Secretary Mary Lou Sutters, social worker, born to be Health and Human Services Secretary in somebody's administration, and thank God it's ours, agreed to chair this along with the Attorney General, Maura Healey. And they held a series of forums, had about 1,000 people come, speak and testify. Incredibly compelling, poignant, and informative conversations, literally that ran the gamut from prevention and education strategies to interdiction strategies to treatment issues. You couldn't have asked for a broader representation of sort of society's points of view. You had recovering addicts come and speak, you had family members, you had people who'd lost family members, you had professionals at every level of the care delivery continuum. Really compelling stuff. And I came away believing a few things from all of this. One is that we need to be very smart about the way we handle these capabilities as a state and as a healthcare community, period. And if you look at just the data over the course of the past 15 years, the number of opioid prescriptions has gone up by about 3.5 times over that period, to the point where in just the United States there were 250 million opioid prescriptions written in 2012. And the number of opioid-related deaths has gone up at almost exactly the same rate over that period of time. And all the elements around treatment have done the same. And there have probably been some major improvements in pain management along the way there that have come with some other consequences that are really what I believe we should be focusing on going forward. And I'm one of these people who thinks that you can't solve this problem if you don't engage the healthcare community and you don't make them a large part of the dialogue, because according to many people, including the Substance Abuse and Mental Health Administration in Washington, 80% of the people who end up addicted to heroin started on prescription pain meds. Now, we can get into a debate about how much of that was through a fully authorized and legally prescribed pain med and how much of it was through something they accessed through some other means. But the simple truth of the matter is, it's very hard to argue that heroin on its own is the issue. There is definitely a direct connect between pain medication and heroin that shows up in every single study I've seen and all the data I've seen. And frankly, the vast majority of the stories that were told by the people who came to speak at the public forums that we all put together. Now, in Massachusetts, we have a prescription monitoring program in place. Used to be voluntary and is now mandatory. I think for physicians, it's up to around 80% participation. Although participation and follow-through and execution tend to be two different things. It's a complicated system to use. It's 11 clicks. One of the things we're going to do is try and get it down to 2. We also need to figure out how to tie it in with some of the other states that are in our region, because there's a lot of stuff that goes on a cross-border basis. By the way, this was one of the #1 issues that the governors in New England and I ended up talking about the first time we got together, which is how can we do a better job of coordinating all of our prescription monitoring activity between and across state lines, so that we have the ability to share one database and one set of information about what's going on with respect to prescribing and prescribing patterns. Second thing we did was we published overdose data and death data on a county-wide basis in Massachusetts. And, you know, there too, the data that you would see nationally is reflected in the state statistics. And the most important one, of course, is in 2014, there were about 1,000 opioid-related deaths, which was a 50% increase over where it was a couple years before that. And the number of overdoses, which is a little harder to collect the data on, is gigantic by comparison. And that one in particular remains a significant problem. If you look, you just take Plymouth. It's one community in Massachusetts. I was down there a couple of weeks ago and talked to a bunch of folks about a whole variety of things. But at that point in time, they had one overdose registered at Jordan Hospital, which is the Beth Israel affiliate down there, that had one overdose for every day of the year so far. And Plymouth is not that big a place. But it just speaks to the prevalence of this that I think is much broader and much more significant than many people realize at many points in time. Now, the working group that we've put together that Mary Lou is chairing along with the Attorney General has representatives from the medical community, it has representatives from organized labor, it has representatives from the addiction community. It's got a lot of, I think, the right kinds of people in place, and I'm hoping that what it will do with its recommendations, which are due out next week, and unfortunately that means I have to come talk to you about the problem and the process. I really can't talk to you about the product because I don't want to get too far ahead of the work that this group has done. It's going to basically have three major components to it: what we should be doing around prevention and education, what we should be doing around interdiction and intervention, and what we should be doing around treatment. And my hope is that it's going to build on the work that was done previously in 2012 and 2013, and try to get us to the point where we believe we're actually starting to at least even the playing field a little bit with respect to the data generally, and take some of the run rate out of the overdose data, the addiction data, and the death data, which frankly at this point is running with a tremendous amount of momentum, all in the wrong direction. The one other thing I'll say, and then I look forward to the Q&A. I'm smart enough to know that, or humble enough to know, that any one initiative with regard to this type of thing is unlikely to get us to where we need to go. But there have been examples that have been demonstrated by some of the players in this space that have turned out to be pretty effective. I mean, Blue Cross Blue Shield of Massachusetts, which is the largest health insurer, worked with folks in the pain management community, folks in the addiction community, and folks in the care delivery community around creating a more aggressive approach to medication safety. They spent a bunch of time talking about it. They spent a bunch of time on acute pain, a bunch of time on chronic pain. And their end game was to try to come up with a set of guidelines that the provider community and the plan could agree on with respect to a more, what they would call sort of appropriate and responsible use of opioid medications. And in the first 2 years they put it in place, they saw about a 25% reduction in overall opioid prescribing patterns, and one that they believe, based on their ongoing conversations with the folks that they've been working with in the provider community, has been pretty effective at achieving its stated objectives in terms of making sure that they continue to provide the kind of access they need to for the people for whom these medications are critically important. That's obviously one example. It's only a start, but it does speak to the fact that if you bring the right people together and you engage in the right kind of conversation and you're solution-oriented in what you're trying to do, you can make progress on this, and you can make it in a relatively reasonably short period of time. We're talking about a 3-year window from the start of that dialogue until the point where they actually got to where they are now, and they feel very good about the likelihood of continuing to build and improve on that going forward. The one other thing I would say, we have tremendous resources, intelligence, capabilities here in the Commonwealth. You're within a few blocks of a huge piece of that. But this is one of those types of issues that, based on what I heard, both as a candidate and as somebody who's been talking to people about this since we took office, is this is going to require the full focus and attention of everybody who has a role to play in this if we're going to be successful. And I certainly hope that the work put out by our task force next week, combined with a lot of the good work that other people have already started at events and conversations like this, can actually move the needle on this in a pretty serious way in a pretty short period of time. I don't want to be looking at the same type of statistics with the same type of trends and the same kind of momentum 3 or 4 years from now. We have to be able to do better than that. And I thank you again for being here, and I appreciate the opportunity to speak. Thanks very much.
I'm going to ask that you use the microphones for the questions. Maybe Michael can, we'll pass the microphone down to Dr. Creek so she can answer. Secretary Sutter, we're happy that you've come and chair the committee. Ask that you keep your comments brief on your questions, and I'm going to get the first one for Secretary Sutters. I know you can't give us the scope of what's coming in 7 days. Can you give us any indication of you think you're on the right track, there's real solutions or progress coming down, or maybe you can't comment at all, but I'm going to ask you that anyway.
I sort of like, good morning everyone. I sort of liked his answer, which is we can't really tell you what we think the final outcome is going to be, but it's going to be in 3 areas. So one is clearly a strong focus on prevention and education and targeting youth in terms of understanding the powerful nature of medications and giving hopefully teachers, kids, and parents the tools they need to understand both the positives and the negatives of these medications. Clearly targeting resources around addressing addictions as a chronic medical disease, which all of you know, of course, but that this is a chronic medical condition and that we need to provide acute treatment, intermediate care, and longer-term recovery and supports. So that's clearly going to be a focus of what I believe will be the recommendations from the group of 16, as I refer to them now, and clearly then focus on recovery. And whatever we can do to help decriminalize the treatment of addictions and to create access to clinical pathways. And I see a few people nodding their heads, so hopefully that gives you enough to sort of chew on. It's a robust committee. It's a group of strong opinions. I've been using my group work skills as a social worker to keep them together, if you know what I mean. But it's all the tools in the toolkit that in order to address the needs of people with addictions. And as you know, as clinicians, there's no such thing as the addicted. There are people with addictions with a full range of needs, from short-term acute treatment to longer-term treatment. So if nothing else, I hope we will forever ban the word the addicted, because these are individuals with unique clinical profiles, and we need to address their needs and the supports of their family.
Why don't you mention the hotspot thing, which is sort of an interesting development?
This is why we like to work together. He sort of reminds me what I should be saying. So one of the first commitments we made when the governor took office was he ordered me, kindly as he does, to get out the data. So the first thing we did, and who knows, what the history is of why the data was not made available, is we put forth 2 years of death data. It's county-based, but obviously it's actually by municipality. We'll be using that data going forward in what we've referred to, and as any of you who have, MPHs will be using hotspotting data to really try to target some of our resources in the Commonwealth to where there's clearly very high need. Now, you could argue that all 351 cities and towns have high need, but really using sort of the hotspotting thinking around targeting resources to really try to have an immediate impact.
I'm going to ask people to, I'm going to ask you to identify yourself for the governor and the secretary, and very briefly tell us what category of health professional you come under: addiction medicine, pain doc, PharmD, that sort of thing. And I'm going to start with Professor Savage.
Yes. Hi, Seddon Savage. I'm a pain medicine physician and an addiction medicine person. Probably pain little has an edge over addiction, but I work in both fields. Thank you both for the work that you're doing. I'm honored to be the co-chair of the New Hampshire Governor's Commission Task Force on Opioids with James Vera from the Attorney General's office there. And we appreciate the work that you're doing. We're really looking forward to your report. One quick comment and then a question for you. Comment with this emphasis on treatment and thinking about treatment of addictions, I'm hoping you're also including an emphasis on more multidimensional treatment of pain. Many of us find that medication visits and procedure visits are very well reimbursed, but that pain is a complex biopsychosocial problem, and we really need to emphasize treatment of the whole person. So I look forward to hearing about that. My question is, we used to have, or the very beginnings of a wonderful interstate governors commission on opioids, and it was off to a wonderful start, and we haven't heard of it in a while. So I'm hoping there are plans to work collaboratively. New England is a small area with a lot of cross-border issues, so I'm wondering if that's in the works at this time.
I didn't know there was an interstate governor's pain management. What I will say, though, is that I've now had 3 meetings with my colleagues in the other New England states, and at every one of them we've ended up having a conversation about a number of topics, including this one. And the primary focus in the short term has been around coming up with a strategy around the PMP issues and the cross-border issues associated with that and the sharing of data. But what you're making me think is whether or not there's I'm going to go back and do a little homework on whether or not there's already an institutional memory and some infrastructure in place that I don't know about. Okay.
So, yeah, great. That may be helpful to your work.
Okay.
Thank you so much.
Say hi to the governor for us.
Yeah, Michelle.
Can I go to the microphone back there?
Hi, my name is Pam Maggi. I'm a nurse practitioner. I'm a New Yorker. We have a lot of regulations in New York State. We have mandatory monitoring of controlled substances. My question is that I'm finding in working with the patients I do work with, most of the problems they have are mental health issues. Insurance covers very little. And my question is that part of your arm that you're working with is to get more coverage to help work with these people? And also, incidentally, where I live, I have some friends who work in the police force, and they're finding individuals are having trouble getting their hydrocodone now, and heroin is much cheaper. So we're having a big issue in our area with heroin. So my question is the mental health issue more, and the insurance and getting coverage for all these individuals who have all these issues. So
there's 4 or 5 questions in there. I'll land on the ones that I understood. The first one around insurance coverage. One of the interesting things about this issue in Massachusetts, and Mary Lou and I have talked about this, there were a whole series of initiatives around insurance coverage that were part of legislation that got passed in 2013 that actually take effect in the fall of this year. And I think one of the things that's going to be important for us to remember is that was a phased implementation, and there are a series of initiatives that literally take effect, I think, in October of this year with regard to insurance coverage that will expand pretty significantly the available insurance coverage in the Commonwealth for this. I think your issue about mental health and substance abuse is spot on, and it's something that the working group has talked about quite a bit. Do you want to talk at all about that without getting too far?
It doesn't hurt that your secretary is a former commissioner.
Yeah, I mean, she's the former commissioner of mental health. I'm a former health and human service secretary. I mean, to some extent, one of the things that happens in government a lot, and it comes back to the previous commentary about hot spotting and data, is we collect a lot of data in a lot of parts of government that we don't ever really use very much when we're actually making decisions about how to allocate resources and programming. And one of the things I'm hoping comes out of this is a little less fragmentation and a little more sort of holistic approaches to the way we deal with that. I would certainly argue that the way mental health and substance abuse programming has been set up has been pretty fragmented as well, and that's certainly something that Mary Lou, as Secretary, has tons of experience to deal with going forward.
So the governor has time for only one more question, and we're going to give it to our other keynote speaker, Professor Creek.
Thank you and congratulations, Governor. I'm Mary Jean Creek from the Rockefeller University, professor and head of the lab of the biology of addictive diseases. I compliment both of you, and I give you both my cards to be willing to call upon me. I've donated my second-born child to the Massachusetts General Hospital. But let me tell you, the one thing that I hear you speak with passion, and you've got it. Stigma is our #1 national problem. But all the parents and relatives and friends that told you about the horrible, horrible problems of addiction, specifically prescription opiate leading to heroin in New York City, as you've just heard, $8 to $40 a pill down to $2.50 for heroin. Let me just suggest 2 additional things. Try to get rid of the stigma, and you're doing that. I mean, the 2 faces speaking out with passion. But also, you have several major universities, including yours, and major medical schools. And most medical schools have less than 2 hours of curriculum on addiction, less than 2 hours of curriculum on pharmacokinetics and pharmacodynamics. Could I get
We
together
know,
with you?
okay?
I think we speak with one voice, yes. And I think with your persuasion and your obvious charisma, meeting the people on the people's grounds, you could personally start with your own school, and my little girl is downtown, and start with others and get the education there. I'm proud to say the Department of Medicine at Mass General has just instituted treatment of addiction with buprenorphine naloxone. We need to increase buprenorphine naloxone and methadone maintenance. Where you have the need, we need to do a lot more with primary prevention and intervention. But all of this requires getting rid of stigma. I suggest a TV show Sunday morning at noontime, just saying what we need to do for the state of Massachusetts and our country. And remember, Romney Obamacare started here. You got the way to pay.
So Sunday at noon, like an hour before the Patriots games come on.
Just tell Mr. Kraft you have to go on first. Okay? Thank you very much.
By the way, you're right about the graduate medical school education piece. It's an in-service education piece as well, not just for people newly minted into the profession, but an understanding and an appreciation about how the stuff works going forward. And we've actually had several conversations with folks about these issues and about the in-service piece as well. And that has to be part of the conversation going forward. We agree on that. And again, we really appreciate the fact that this conference is happening. We really appreciate your being here, and we especially appreciate the fact that you're having it here in the Commonwealth of Mass. Thanks very much.
Thank you.